Hi, this is the fall prevention presentation for NU 317. What is the problem? The issue is that falls and falls with injury are the #1 commonly reported adverse events in the hospital setting. It can lead to preventable patient harm, increased length of stay, and increased healthcare costs. All healthcare settings must assess patients for fall risk and report falls as an event. In the United States, approximately 700,000 to 1 million patients fall annually.
Fall risk factors: biological risk factors, muscle weakness or balance problems, medication side effects and or interactions, chronic health conditions such as arthritis and stroke, vision changes and vision loss, loss of sensation in feet behavior risk factors, inactivity, risk behaviors, standing on chair in place of a step stool, alcohol use, environmental risk factors, clutter and tripping hazards, poor lights, lack of stairs, railings, lack of grab bars inside and outside of tub or shower, poorly designed public space.
Current practice. A review was conducted of 3 different healthcare facilities on what fall prevention protocols they currently utilize. Each facility uses different protocols. Facility A, Facility B, Facility C. Facility names have been removed for the purpose of this presentation. Facility A. Fall risk assessment is analyzed on the review of systems assessment, which is based on a number score, but currently there is no implementations regarding what to do for the patient in each score category. This assessment is completed each shift.
Facility B. Patients will be assessed on admission to the dialysis facility and on an ongoing basis on the stable/unstable criteria established for the care planning process. This assessment will be in conjunction with the general nursing assessment. The fall risk assessment is a component of the nursing assessment and will be used to determine if the patient has standard or critical fall risk factors. Standard fall risk, a score of 5 or less on the fall risk assessment. Critical fall risk, a score of 6 or greater on the fall risk assessment.
Facility C. Components of the patient safety program include member education strategies and the importance of medication review and adherence, regular exercise, identification of environmental factors, and completion of a fall risk self-assessment. Physician education strategies included adaptation of nation best practice, evidence-based clinical guidelines, and materials to assist with fall risk screening, assessment, and management.
What needs to change? Patient-family education implementation, fall prevention program, identify who is at risk, risk assessment, assessing score and what to do when they fall into different score bracket, medication management, physical and occupational therapy, assistance devices use, and education.
Why does it need to change? Because of the consequences of patients' healthy lifestyles, falling prevention has been treated as a matter of priority in health institutions, and it is part of the global patient safety movement that began in the 1990s and culminated in Brazil with the publication of the Ministerial Ordinances and Resolutions of the Collegiate Board of Directors, RDC, in 2013, which determined the adoption of a policy focused on patient safety by health institutions as well as protocols related to the 6 international goals of patient safety, one of them being the prevention of falls, which is an indicator of quality of care.
As a result, the following EBP is being proposed. Among hospital inpatients, how does a patient-centered fall risk education program compared to a standard teaching impact fall rates over a 90-day period? Our first article is an inpatient fall prevention from a patient's perspective. It was a qualitative study. The purpose was the aim of the study was to describe the patient's perspective of fall prevention in an acute care setting to aid in the design of patient-centered strategies. The method was to understand the patient's perspective. They used semi-structured interviews. It was reviewed by the local institutional review board. It was conducted in a large urban tertiary care academic health center in the Midwest. Participants were selected from a non-intensive care unit, and a verbal consent was obtained. The limitations were that they were in only one non-intensive care unit in one facility. It also lacked cultural and ethical differences since everyone spoke English. During the interviewing process, the facility piloted and spread standard work for fall prevention process, which implemented intentional patient communication regarding fall risks, use of whiteboard communication, and the standardization of equipment usage. Does not address patient and family-centered strategies that may decrease fall risks. There was 3 major themes with subcategories. The first was how I see myself, or how they see their own fall risks, with the subcategories of awareness, acceptance and rejection, implications, emotions, and personal plan. The second was how I see the interventions, or how they see the fall interventions put into place by the nurses, with the subcategories of what I see and hear and usefulness of the equipment. The third major theme was how I see us. 9% felt that they shared the same prevention plan as the nurse. Those who the interventions in place were useful did not describe any barriers in participating in the fall prevention plan. Time spent waiting was the most frequently mentioned occurrence that negatively impacted the partnership.
And this is the second article that we did. The purpose of the study was to analyze the adequacy between the evaluation of the risk of falls in adult patients and prevention measures that were adopted. The method that was used, the study looked at 1,408 hospitalized patients within different areas of the hospital. The data was collected using the Morse scale and an evaluation of bed fall prevention measures. The data was then tabulated in the Microsoft Office Excel 2010 program. Limitations. The study concluded by establishing some limitations. One was the noted limitation that the study is not analyzing all falls that have occurred due to underreporting, and 2, that health professionals aren't fully trained. 3 findings. The study results showed that of the areas evaluated within the hospital, which included the medical surgical unit, the ER, and the ICU, the high risk of falling score was more prevalent in the medical surgical unit at 21.6%. Another finding proved that 33.9% of the patients were over the age of 60. Other findings, one was a connection to venous infusion equipment was pretty high at 90.1%, and then history of previous falls was 59.9%, and disorientated mental state was 34.0%.
Third case study was Fall Safety Agreement, a new twist of education in hospital elderly adults. Purpose. The aim of the study was to further explore falls occurred in elderly individuals greater than 65 in an academic medical center. This was done through secondary analysis of a pre-existing fall database. Method. Retrospective, quantitative, explorative, descriptive study design was used to analyze data from pre-existing fall database. Data were analyzed from patient 18 years old and were spread into 2 separate groups, 18 to 64 years old, 65 years and older. Limitation. The limitations to this study was that the data was taken from post-fall huddle database from information entered by staff. This could have affected accuracy of data. This is a non-experimental study that did not provide the ability to establish cause and effect relationship. Findings. The assigned JHFRAT score was reported for the sample. The greatest percentage of falls occurred when the patient was in standing position, 4.5%, whereas most of pre-patient activities was unknown, 84.8, 92% of falls were unassisted, and 60% occurred in medical surgical floor.
This is the fourth article, which is the effectiveness of multifaceted and tailored strategies to implement a fall prevention guideline into acute care nursing practices. A before and after mixed method study using participatory action research approach. The purpose is to assess the effectiveness and require time invested of a multifaceted and tailored strategies for implementing an evidence-based practice prevention guideline into nursing practice in an acute care hospital. This was a mixed method design that was used with the participatory action research approach involving 2 departments of an Austrian university teaching hospital that included all graduate and assistant nurses. Qualitative data was content analyzed using a template, and qualitative data were distributively analyzed using appropriate tests for independent groups. The theoretical framework for the study was consolidated framework for implementation research. Limitations was that it was not possible to analyze the before and after changes with a paired t-test. Each questionnaire was marked with a personal identifier, and the identifiers were repeated, making it hard to decipher who the person was. Only less than 20% recalled their identifier. This study took about 18 months to complete. It is not possible to analyze the potential effects of the participants' working area due to them not asking where they were working. And each questionnaire took about 40 minutes to complete, which caused a lot of turning down. Findings. This study increased knowledge of fall prevention, how to access fall CPG, the fall guidelines, and awareness of fall prevention in graduate and assisting nursing.
Article 5 was most and least helpful aspect of fall prevention, education to prevent injuries and falls. Purpose. The effort is ongoing to evaluate the effectiveness of hospital-based fall prevention interventions. Inconsistence of staff being unable to recognize the importance of some fall prevention interventions in patients' risk factors for acquiring fall-related injuries. Method. The qualitative data used in this report are from exploratory nurse survey study that was conducted at the 5 nonprofit health system located in Midwest region of United States from July 2011 through February 2012. Limitations. Limitations of the study is that the data should be treated with caution as the study units as RNs are voluntary. With a low response rate, the data may not reflect the true measures of sample. Findings. The findings of the study showed of the 560 completed surveys, 465, which is 83%, received, and 67, which is 12%, did not receive fall prevention education in the past 12 months. 28 of 5% did not answer this question. The most common model of delivery of information came from verbal messages, followed by printed materials, computer materials.